Thank you for the invitation to speak here, and I will go through some of the main reasons why we think that dynamic CT perfusion might be helpful. As was just stated, I'm a cardiologist, so I tend to look at guidelines when I try to see whether a new test is helpful or not. And I'm hoping that most of you are familiar with these recent ESC guidelines on how to evaluate patients with chest pain. Unfortunately, they are new, but there are not that much novelty in the contents. One thing that I would like to focus on here is that the coronary CT is entered into this chart that kind of displays how a patient with chest pain should be evaluated. Should this be the first choice always? Well, if you read out here, you can see that sometimes maybe it's not a good idea to use this because ischemia testing is not really something that's normally done with coronary CT. So sometimes you would like to have an ischemia test as the first choice. Having said that, why not do both in one? And that's, of course, the great thing about doing CT angio and CT perfusion, that you may possibly do everything in one test. A very difficult question that I always ask myself, and I think you should also ask yourself this question: when do you think that a coronary lesion is significant? This term significant, everybody uses it, but we don't really know what that means. I guess most of you here are physicians, so we have our own definition, but I would make the point, the most important definition on what is significant is what the patient thinks. And most of the patients, they're interested in knowing, this problem that I have, is that something that will be limiting my quality of life or maybe even limiting the lifetime that I will have? Will I die from this? So in terms of significance, we should always think about what does that mean in terms of morbidity and mortality. Well, what does that mean again? For physicians, it's really, really difficult. So we tend to look at measures that we can use, that we can transform into, well, this is, if it's significant, this finding, then we think that something needs to be done about it. And of course, we have different approaches to look at this. The pressure gradient, that's an invasive measure of the pressure gradient, or it can be possibly done non-invasively by CT-FFR. We could look at whether there is ischemia on a myocardial perfusion. And I put something here that also is very important, is, well, significant. What that means also is that if we are doing imaging, it means if it's significant, is it suitable for PCI? That means that if you find smaller vessels where you do think it is with hemodynamic significance, if they can't put a stent in there, then is it still significant? Well, invasive cardiologists, they tend to define what is significant, a lesion that can be done something about. Yeah, it's a joke, but just make sure that you know what significant means when you have the next reading of a patient result. The invasive FFR measure, that's a great example of how it should be done to kind of check out whether a new test is helpful or not. This is an old study. What they looked at here was that if you just do the anatomy, compared to if you, on top of the anatomy, measure the functional significance of the stenosis. And what they were able to show here is that if you combine anatomy and function, you probably have a better outcome than if you just have the anatomy. Of course, this has been discussed and contested many times after, but just having the principle that having combined anatomical and functional assessment is probably a valid statement, and I think that most of us agree that that would probably be the way to go. We tried doing this just from the angio to see how far we can go just from having an angiography by CT. And I'm sure you're all familiar with these ways of looking at the stenosis. This is before, at the stenosis, and after. So you can measure the area stenosis by CT if you have a really high quality study. And what we did here was we compared the stenosis severity with the invasively measured FFR. And, well, there was a signal. So possibly you can get some idea of how so-called significant this lesion is just by doing the area of stenosis. But you can see there's a huge amount of scatter here. And I guess for clinical purposes, the area of stenosis is not as good as that we would like it to be. So we need more. I'm sure you're all familiar with CT-FFR. Many different approaches has been used. We have some experience with this. And I guess to defining whether a lesion is potentially PCI material, probably CT-FFR is helpful. The problem right now is that the data that's out there is almost exclusively observational. There are no randomized trials suggesting that CT-FFR is actually helping the patient. It's helping the physician to make a decision, but is it helping the patient? We have no idea. This is an area that will need more work, but I'm sure we'll get there at some point. Another area that's more interesting or equally interesting is perfusion. And let's just pulled out this interesting observational study it's a while ago that was published. Look at that, 7,000 patients. And the outcome here is cardiac death. What it means is that if you have a high percentage of the left ventricle with an ischemic signal on PET, that's dangerous. And the time here is 5 years. So it's kind of robust that if you do have ischemia in your myocardium at a large extent of the LV, well, you should probably be concerned and you should probably do something about it. This is just done by PET. Possibly you could replace that with SPECT. Whether it can be replaced by MRI or CT, I don't know. If there's data out there, there might be, but I just took this because I used to work with PET imaging many years ago. So now focusing on what can CT do in terms of myocardial perfusion. And I'm sure you all have seen an image like this before. It's just a CT angio that all of you are doing, I guess, just playing around with the window level. And what you can see here is that the Hounsfield unit opacification of the myocardium, well, maybe it doesn't present that well on the screen, but it looks reasonably homogeneous. But what happens if you, in the same patient, infuses adenosine and do exactly the same CT, just a CT angio, just do it once more? Here you can pick up that there is low contrast uptake in the subendocardium of the myocardium. This basically represents how static myocardial perfusion imaging is done. And we went into this field a couple of years ago and said, well, this is quite easy, or apparently quite easy. So let's see how far we can go with using this approach. We did some initial studying of what is the relationship with I think it's blue, or is it black? The relationship between severity of coronary stenosis and a static measure of perfusion by CT. And what you can see here is that at the rest, you should reach a point of more than 90% before you see a decrease in the blood flow. That's consistent with what is already shown in physiological studies. So we were very happy about that, especially also because if you look at adenosine stress, when is the point where you see decrease in flow? Well, that's around 50%, which is what we normally call a significant stenosis. So evidently, the CT static perfusion imaging, you can get some information on what happens in terms of functional implications of a coronary stenosis. Does it change the outcome if you have a large extent of perfusion defect by CT? Well, this is a very small study also, but illustrating similar findings as what you saw with the PET, that if you have a larger area of this PD, that's perfusion defect, if you have a large area of perfusion defect during adenosine by CT, the prognosis is poor, just like what you see in PET. you can, of course, notice that this was just more than 10%, whereas at PET, we reached the 20% area or the threshold. So we don't really know what the threshold is for having a poor outcome if you have ischemia. But I'm just stating the fact that static perfusion, you do have prognostic information there. How do we figure out whether a new test is helpful or not? Well, somebody says, well, let's just do it and see if we think that it's helping. Of course, that's easy, but it's not very scientific. So the way you should do it is by randomizing patients to the old test and the old test plus the new test. And we did that. This is the CATS-2 trial where we had the CT alone and the CT plus CT perfusion. And depending on what was found on these, either just CT or CT combined with CT perfusion, the patient were referred for invasive evaluation and revascularization. What we saw here was that if you do CT perfusion, much less of the patients ended up having a referral for invasive cath, because many of the stenosis that we thought was by visual analysis was significant probably weren't, because there weren't any perfusion defects. And how does that translates into revascularization? The proportion of patients undergoing revascularizations was much less if we did both CT and CT perfusion. And when we showed this, people said, my God, can you do that? Send them home without doing revascularization? And there was no difference in outcome, which means that when you add on CT perfusion, you limit the number of patients that actually go to revascularization, and the outcome is the same. So some of the patients that entered the CTA group, they had revascularization that they probably didn't need. I think it's very interesting. Not only the outcome was similar, the symptoms were also similar. I just skipped that slide, so I don't have that on here. Just to summarize on what are the advantages of static CT myocardial perfusion is that it's simple. It's very simple. Anybody can do it. Just do an CT angiography and then add on a second CT angiography, but with adenosine. And coming from that, the radiation is low. The major disadvantage of this test is that it's very difficult and demanding to interpret the images, because to pick up these very subtle changes of the differences of HU values in the myocardium, it requires a fair amount of training. And furthermore, you also see a fair amount of artifacts in there, so yes, it takes time. It can be done, and if you're trained, you can do it, but in my book, if it's that difficult, maybe it won't take off in that huge amount, because if it can be done just one site in Denmark, it doesn't give much benefit for the huge amount of patients that we would like to help. Okay, so data output. Well, also a limitation is that this is only semi-quantitative. We would like everything to be quantitative in absolute numbers, if that is possible. And so this is why we moved to the next development of perfusion imaging, and that's dynamic, where we don't just take one single shot here. We do multiple imaging at low radiation. So what you can do is you can describe how the contrast arrives to the myocardium and how it is translated through the myocardium. So you can have a more quantitative assessment of the perfusion in the region. Yeah, this is how it looks like. I'm sorry it's quite slow, but it's actually real time. And you can see here first right and then left. And this is the curve, this is the input curve that's drawn. And can anyone figure out why I'm showing this? Waiting for 30 seconds or 25 seconds? Well, you can breathe now. What it means is that the breath hold is very long. So, of course, this is a working area where we need to figure out, can it be done in a shorter breath hold? But that's kind of the fact of life, that if you want to get good data, the patient has to hold his breath or her breath throughout the 25 seconds. And as I just showed you, you get the input function and you get what is a normal myocardium. If you have an abnormal myocardium, it will be lower. So it's just a very simplified way of describing how would the different types of tissue look on the curves. And the key features, just to listing up here, breath hold is somewhat long compared to what we normally do. For the Canon scanner, you can do whole heart series imaging, which I think is very important. If you need to kind of do several imaging at each time point, or how that is worked out, I have no experience with this. I'm just saying, if you want to have the curve for the whole myocardium, you need the whole myocardium for every beat. So you do a serial low-dose heart-by-heartbeat cardiac volume acquisition, and of course it goes without saying that if you have if you have a high heart rate, the time where you scan will be lower. You do a boost phase, which means that you increase the radiation, so you actually can see a high-quality angio. And out of it comes, and here is the important point, you get the semi-quantitative data, automated analysis of both semi-quantitative and absolute data. And this, I think, is the biggest advantage so far from what we've done, is that because you have much more data to work on, the automated assessment is much more credible, and it can be very fast. And you don't need, actually you almost do need no training, because you can just load the data in and the numbers are there. And that's very important. This can be done several ways. We still do the rest first because we think that the anchor is the most important one. Because if the anchor is normal, you don't need the stress. But we do rest and stress. And as I said, the analysis is automated. It takes about 5 minutes. And this is what it looks like on the output on the workstation. I hope you're familiar with this. This is the bullseye plot where you have rest and stress. Of course, the middle portion of the circle, that's the apex, and the outer portion of the circle, that's the base. And then you have septum, lateral, anterior, and posterior parts of the left ventricle. A kind of easy way of summarizing the findings. Does it work? There are not any publications out there yet, but this was one of the first ones where they compared the dynamic CT perfusion imaging with what is considered the gold standard in any human measure of perfusion. That's oxygen water. It's not rubidium, it's not ammonium, it's oxygen water. And the reason for oxygen water being the best one is that the extraction fraction is 100%. So it's the most reliable number that you get out of there. And you do see some relation here. This is the PET and this is the CT. And these are absolute numbers and these are flow reserves. So from initial experience, it does look promising that you can do absolute numbers. Whether it clinically is helpful to do absolute normal, we don't know yet, but it's just the starting point that it can be done with CT. I thought about just doing a couple of cases before I wrap up. And so this is one case. Please appreciate that this is done in a research environment, so you could argue what is the clinical indication for a CT in this patient, but it's just to illustrate how things can look if you do a CT where you have these complex situations. So this is a 68-year-old male, normal risk factors, chest pain, and he had actually had a minor TNT elevation during an admittance. And it was assumed to be hypertension, but yeah, probably you know that troponin is somewhat difficult in the emergency room to really figure out what that means. But he ended up having a test, a rubidium PET, and already there you might expect that there was something wrong. At least he was referred for invasive cath, but before that, we did a CT. And that was the CT with rest and stress. And at rest, you get the angio, and I'm sure you can all see here that the severe stenosis of the LAD, right coronary CX are normal. Maybe there's a slight plaque here, but this is certainly highly significant. And at that point, you would say, you don't need more, that's it. We're ready for revascularization. And you will probably be right, but I'm just showing you what does it look like when you do the dynamic. And what you do here is you just load the data in. No adjustment, no nothing, just put it in there and out comes these numbers. We tried to see if we could help the machine and see if the segmentation was better when we did it by manual. It was impossible to do it better. So it's very fast. And what you see here is at rest. At the apex, there may be already at rest some, and the blue is called, of course, low flow. But at stress, it's much larger, consistent with a severe LAD stenosis. And that was, of course, confirmed by the invasive cath. Another, a little more complicated patient, 67-year-old male, history of hyperlipidemia, 5 years of smoking. He had an inferior STEMI a couple of months ago before the investigation. At the time, he was diagnosed with a CTO of the LAD. The STEMI was taken care of with a stent in the right coronary artery. So he came for a second revascularization procedure, and the rubidium just showed a 20% reversible ischemia and the anterior wall, consistent with what was expected at the occlusion region of the LAD. Of course, also a smaller defect in the posterior wall, which probably was sequelae from the STEMI that was in the right coronary artery. So again, maybe not a very strong clinical indication for CT, but we did it anyway as part of a research protocol. And what it looks like here is CTO, current total occlusion of the LAD, right coronary artery, looking really reasonably nice. There's a stent there, it looks open. CX with some disease. Well, as you know, we can't really make a real firm diagnosis of this, but there is some disease there. And so what is the guess? How does the CT look? There was a resting perfusion defect at the right coronary artery area. So probably the STEMI with the stent implantation was still too late. At least there was still some area with normal perfusion. In the LAD region where we saw a CTO, there was some hyperperfusion which was extended or increased in size during the stress, consistent with what also was found on the rubidium. So far, so good, looking very promising, and at least consistent with what we would expect when we have the rubidium results. Yeah, we can just skip this, but this was the LAD occlusion. And so my take-home messages are that the definition of significant current stenosis should always be related to what clinical outcome you would like to impact on. Think about that when you give a report saying there is significant disease or problem on your non-invasive tests. Be sure that you give the right advice to the patient. Dynamic CT myocardial perfusion provides semi-quantitative and quantitative assessment of regional global myocardial perfusion. And of course, especially in patients with borderline stenosis and or issues of image interpretation, I haven't covered that, but of course, we all think that CTA always gives perfect images, but we always also know that that's not true. So if you don't have a perfect image at rest and you think there's something there, maybe a dynamic perfusion on top of that to see if the perfusion is normal would be helpful. So yes, thank you for your attention.